Hi, this is Terry, the founder and director of Deep Sea Foundation. I want to welcome you to the educational channel where we talk about topics related to breast cancer and breast reconstruction. I'm speaking today to Dr. Tim Matatov of Southwest Breast and Aesthetics in Phoenix, Arizona. Dr. Matatov is a board-certified surgeon who completed rigorous training at Tulane University in New Orleans for plastic and reconstructive surgery. He works with a group of 4 other microsurgeons. They perform a variety of autologous-based tissue reconstruction, second-stage reconstruction, implant reconstruction, and corrective surgery, to name a few. The information will be in the video description and also the end credits with contact and location to find Dr. Matatov's practice for those who are interested. I realize that I often use the phrase, we're going to take a deep dive during my interviews. Yeah, I know you're smiling too, Dr. Matatov, but it's so, I feel like it's so appropriate for many of our discussions. Today, our topic is part of the aesthetics of the donor site. So I don't know, Dr. Matatov, I feel like in recent years, I don't know if you're comfortable or care to comment on this, but I personally feel like in recent years, there has been more focus on the donor site in regards to DIEP Flap, which the donor site is the abdominal area. How do you feel about that?
I think it's wonderful because what was happening for a while, we were treating one problem and creating another problem. So I think spending a little bit of time and focusing on functional and aesthetic aspect of the donor side, I think is critical. And you see that, and you hear that from the patients, and from even the transition from when I started just worrying about making sure the flap survives to now it's like, well, how many sutures are we going to put in to make this significantly better looking? I think it's very important. And
Yeah.
some people may say it's a cosmetic deal, but I don't think so. I think it's, again, creating one problem, treating one problem, creating something else. If you don't spend the time, and patients may love their breast, but they may dislike their donor site. And I don't know if I helped them in that situation or not. And it doesn't take that much time or effort to make things better, much better.
Yeah. Well,
So yeah, I agree.
I think that many patients affected by breast cancer would have never thought, present company included, that I'd be walking into a plastic surgeon's office. But I think what happens is that we take a bad situation, those that are affected by breast cancer, and then you combine that with the skill and the artistic eye of a plastic surgeon to make really a transformational, a very positive transformational change in many patients' lives. I heard something at a conference once that I have not forgotten. And someone said, it was a microsurgeon, and they stated, what we don't often realize is that when a breast cancer patient walks into our office, they walk out an aesthetic patient.
Yes,
And
honestly, yes, correct.
yes, and I think that's going to be part of our discussion today. But so what we're going to do, take a deeper dive, Dr. Matatov, and we're going to look at what happens um, to the umbilicus, or it's known, did I pronounce that correctly?
Umbilicus, but yes, umbilicus is the way I pronounce this. But yes,
Yeah.
some people
So
say umbilicus or belly button. Yeah.
yeah, exactly. The belly button. I also want to mention that there are other videos that we've done together on the Deep Sea Foundation YouTube channel. So when you go to the search engine, type in things like, I think we've done one on stacked flap, hybrid flap. So,
Hybrid sound.
right, yeah. So type those into the search engine for those of you who are listening. Also, we did one on fat grafting, the second phase, which that was
Second
most,
phase, that's correct.
yeah, that was most recently, and that got
Balancing procedures, yeah.
yes, yes, yes. So look all those up, and I'll make a list of those in the description too, so patients can reference those. But let's go. I know we've got some a couple of slides that you want to share today, so I'm going to let you tell me when you'd like me to show those. But overall,
Okay.
let's start with what happens to the belly button during DIEP Flap. I'll let you take over.
Okay. Um, I think it's probably a good time to look at the slide, and we
Okay.
kind of start from there, and everything else can be imagined.
All right.
Um,
Let me pull that up. Okay. Can you see that, Dr. Matatov?
yes, I can.
Perfect.
So I know there's a lot of information on the slide, but the main thing we're focusing on, and I think it's a really good depiction of the umbilicus. So the second from the left, you can see that the flap was already taken out,
Hmm.
and the fascia is still exposed, not yet closed. And then you can see above there's the belly button. So the umbilicus has a dual blood flow to it. One of the blood flows would be the surrounding skin, which is being removed during the DIEP flap, because you do have to make a circular incision to release the belly button from the flap itself. And the second blood flow comes from underneath. It's actually within the abdomen, and that's the umbilical veins and artery. And those are the vessels that the placenta used to be attached to, and that's how you would get nutrients from your mother in the womb. So that's the second blood flow. So during a DIEP flap surgery, you can only take one blood flow away, and you still have to keep the DIEP, let's say, intact to allow for perfusion, so this belly button stalk or umbilical stalk survives. So now it's in this picture, it's only attached at the deep structures. It's attached to the fascia of the muscle, and it goes all the way through. And then underneath, you have those vessels.
Hmm.
And once we've closed all the fascial incisions, and that's the upper incision. We usually go up all the way up to the between the breast. If you keep going up higher, we kind of go underneath to release that, so they can come down lower, because otherwise it won't go that far. So once
Yeah.
that gets right, so that's you lift this up all the way to the rib cage, and then that
Hmm.
allows movement, because now it's detached, and you pull this down, flex the bed a little bit, and this gets closed all the way to the picture to the right. The last picture on the right, it's closed,
So, Dr.
and
Matatov,
then
when you
you'll
say flex the bed, you are talking about physically in the OR, maybe making a beach chair type position?
correct a beach chair position. Yeah, this allows for greater movement.
Hmm.
And immediately after closure, your skin is not used to being stretched. In some patients it is. In some patients you don't even have to sit up. But it's not yet used to being stretched so far. So we flex the patients a little bit in the beach chair position, so we can have what's called a tension-free closure. And then over time, as a week or two goes by, that skin and that tissue slowly stretched over time, and allows for this accommodation to where you can now stand straight, and you're not putting as much tension or pressure on the incision itself. So once this is closed, I before we close, I mark the belly button where I want the belly button on that skin to be, because that currently there's no opening. So once you pull this over, now you've marked that you transposed the belly button location onto the abdominal skin location. And once that lower incision is completely closed, then we make sure the belly button is in the center and at the right location in the horizontal plane, meaning that up and down, where does it go? For most people, it's right about at the hip level on the side, where the hip kind of goes from the front to the back. That's
Hmm.
where it is for most of the patients.
Mm-hmm.
And there is a variation to that. Sometimes it can be a little bit lower, sometimes a little bit higher. Also, majority of patients have it slightly to the side, either the left and the right,
Mm-hmm.
especially after pregnancies. As your abdominal wall stretches, it never goes back to that same location, and the belly button also gets pushed to the side sometimes, and it doesn't always, and is not always centered. So we try to center this as much as possible, knowing that there's some gift to that.
Well, there's
And
so many
there's multiple.
variations too. You've got high-waisted folks, lower, shorter waisted, um,
Absolutely.
skin laxity, all of that to consider.
Yeah, you consider all those things and where you want to place the belly button. Also, before we make the design for the belly button, on some patients, their flap anatomy doesn't allow for a lower scar placement. So the scar can be a little bit higher because, let's say, the best blood vessel and this flap is slightly above the belly button, and there may not be enough skin laxity. So you have to accept slightly higher scar. Yeah, this transverse scar will be slightly higher.
Mm-hmm.
And I usually have this discussion with the patient. For majority of the time, you can predict where this is going to happen with CT scans, and I'll have a discussion with the patient and look, this may be higher, and you have to see if it bothers you. We can have a revision. And most people get bothered by it if they like to wear something that's low cut, and or I know it's very high, and I'm like, I can make this better at the second stage surgery. Then I will on purpose put the belly button up too high. So let's say it was supposed to be in this area, and then I'll put it like right about here. And then when I can go back at the second stage surgery, I open that old scar. Allows me to revise the scar, and then I'll again elevate that abdominal skin up to the belly button, and it allows me to pull it down. As I pull it down, something that was high, it starts to come down back to its normal location. And this way, you can gain about an inch or so by lowering that scar lower,
Mm-hmm.
and also the belly button comes back into the natural location. But that if somebody doesn't need that, then we'll go right where it's supposed to be.
Mm-hmm.
But if I know that it's going to be very high, and we've already had the discussion, the patient's like, I'd like to get it as low as possible, then I on purpose put it too high, knowing that I'm coming back and I'm going to lower it, and it works out perfectly well. In some patients, you can also reposition the belly button in second stage, but sometimes you can what's called floating the belly button. You can go on. So once you've inset the belly button and you allow that to heal, come back in 6 months or so, now the belly button will have blood flow coming through the scar that we've created, the opening. You still have the blood flow from underneath, and you have the blood flow from the surrounding skin, kind of this, it's called neovascularization. And you can come back in and kind of divide the belly button off the deep vessels, float it up, and bring it down to where it's more in a better location, and bring it down the scar. So you can do some of these things. Ideally, you'll get some atrophy sometimes with that. So this way, the best way that I found is to put it high on purpose at the first stage, and then bring it down at the second stage, and lower the scar sort of at the same time, and put the belly button in the correct position.
Yeah, that makes sense
So going
because
back to
during the healing,
yeah.
you have to consider swelling and all of that, which yeah, that makes complete sense. Hmm.
Yeah, it changes some of these things, and sometimes you don't need to do that. It all depends. Where like the longer I've also learned through COVID, the longer I wait between the first and second stage, the less I have to do, because the timing fixes a lot of these things, and just body just adjusts and goes back to more of an anatomic or accepted location, whether it's the breast, the nipples, depending on when you change. So you wait longer. I now wait routinely 6 months, and I have to do less. And I've noticed I have to do less, and potentially a little bit less scars, potentially less surgery. But yeah, that's accommodating for swelling. The swelling can stay around for about 6 months, noticeable swelling, and that's
Yeah,
normal in the abdomen,
yeah.
especially below the scar. So going back to the initial surgery, now that we've closed that incision, we have no belly button. We've
Hmm.
transposed a drawing of a belly button, or at least a mark on the skin where it's going to be. There is so many variations to the design of the belly button. How are you going to make that opening? Some people will make an X. Some people will make a Y. Some people will just cut out a hole, like an opening. Some people do a smiley face. Some people do a frowny face. So there's so many variations. Like I do a smiley face. My partner, Dr. Mino, loves a frowny face, so he'll do a frowny face. And the most important thing, I think, in the belly button opening is not to make it a circle. If you make it a circle, it looks like a target sign. And I tell patients the best belly button is the one you don't pay attention to. That's the best belly button. If you're paying attention to it, something's wrong with it, right?
Wow.
So ideally, you make it in a way that it's as natural as possible. Obviously give and take here. But the reason I like a smiley face, so a smiley face, like let's say if this is the head is here, the feet are here, I make the incision like so.
Yep.
And this allows the upper portion of the belly button be tucked in, so you're not seeing the full circle. You're only seeing partial. You're only seeing 270 degrees of that circle. The A breaks up the scar. The top of the belly button incision is not visible. You still have the sides, of course, but it kind of breaks up that scar. And I like that more of a natural appearance. The frowny face is just opposite. You go like this. It has its also ups and downs to that. I do feel like it gives you a little bit more of a rounded look to the belly button, but it does give you more of that natural lower portion of the belly button has a little bit of a gentler takeoff with the frowny face.
Mhm.
But sometimes you see a little bit more of the scarring. So I like the smiley face, and so is my other partner, Dr. Zachary, and it worked out well so far. And that's what allows us to design a belly button that's more natural appearing,
Mhm.
um, but obviously accepting some scars at the bottom portion, which you can sometimes hide, or with time it'll fade away. And some people will still need some steroid injections just to soften up the scars.
Ah,
But that's the
okay.
design we use, and I've seen many variations of that.
How long does it
Um,
take generally for a belly button to heal? I have a rather personal story on that. So for me, it took a month. I had my DIEP Flap December 1st. So imagine what I was doing on New Year's Eve. It was,
it
it,
was
yeah, it fell off
yeah.
on New Year's Eve and I got to see my new belly button. So it took mine a
Oh,
month.
the dressing tube. Yeah, yeah, yeah.
Well, yes, and I guess to be more descriptive for the listeners and the viewers, it formed a scab around it.
Oh, okay.
And people often wonder, it's like when, babies are born and they have
Correct.
yeah, so mine fell off like a month to the day after I had my surgery. So like New Year's Eve, I'm having a belly button celebration. The big reveal on New
Well,
Year's Eve.
the the big reveal, the something that we've kind of discovered as we've gone through through early on in the career, still early on, but people that have a belly button during the surgery that has still perfusion, but it's not great perfusion, end up doing better and appear more natural than patients that have completely healthy belly buttons.
Hmm.
So if you like you brought up a baby, when you clip that belly button, you let it pour in and scar in. It kind of scars in and funnels in. So if you look at the belly button, it's a little bit of a funnel, right? It's like the
Mhm.
abdominal wall, and then it kind of funnels in. One of the giveaways of a belly button that's surgical is that it's flat and then there's a hole. There's no funneling. So that's one of the things that can draw your eye to it. That's and a telltale sign that something's been done. So if you have a belly button that's stressed, it starts to kind of contract a little bit. And as it contracts, it pulls that skin in. You have a little bit of a more natural appearance to the belly button if that happens. Of course, it's unpredictable who this is going to happen to. We do, it just happens to work out that way. We don't actively or proactively trying to kill the belly button, but we've noticed in patients that, let's say, previous surgical scars around the belly button or some sort of a hernia repair, they tend to look a little bit better. Just be going through that ischemia and scarring in process, just like what the baby goes through. You clip that belly button, it's gonna starts to shrivel up and goes in, and it pulls the skin with it. the abdominal skin, so you have that funneling that occurs naturally.
This is so interesting because I had a couple of questions. You've already answered them about, you know, if you've had mesh before from a hernia or if you. So this is interesting. I posed questions on the belly button to the private Facebook group that I admin, Dr. Matatov. Here's an interesting one to your point about the baby's belly button. And this is from a pediatrician who has had DIEP Flap. So
Okay.
she says, let's see if you can tackle this. I wrote it down. It says, how do you tether? I think you've answered some of this already, quite a bit. How do you tether the belly button to become an innie? What is it pulling toward inside? You've just been talking about this. Do you attach to similar ligaments that the original did? I had a partly out and in belly button prior. Just curious about that anatomy as I'm a pediatrician and I'm at deliveries and cutting cords often, so the anatomical setup is very familiar to me.
Yes, so a couple of things to that. I can answer that question. So part of that is ischemia is what draws the child or baby belly button in, and same thing for somebody who has a belly button that's the perfusion is enough to survive, but definitely questionable. So in patients that do not have a problem, have a longer belly button, what we do, we actually put 4 stitches. So 12 o'clock, 6 o'clock, 3 o'clock, and 9 o'clock to shorten the stalk a little bit.
Mm,
So if your stalk is this long and your abdominal wall is this thick, you're going to be sticking out a good bit.
mm,
So what we do is we put sutures in to shorten that significantly. So it's now more tethered to the fascia. And the more you cut around the belly button or do things, you can also disrupt blood flow. So we're trying not to do a whole lot. But if you shorten the height of the belly button to less than the actual thickness of the abdominal wall, then you get that little bit of that funneling. Also, when I make the smiley face like this top portion, this gets open in the smiley face. This top portion, the top of the incision, we mirror that on the belly button. So you actually have a cutout of a smiley face opposite to what you have on your abdominal wall. So it fits like a jigsaw, but also that allows us to put a stitch into the abdominal fascia to recreate that funneling effect. So
mm.
yes, we do that, and most patients. Some patients, if they have a thicker abdominal wall, it's not so beneficial because it's really hard to have the sutures pull that much. But if you're a body mass index under 30, 31, you should be able to do that. It's a little bit easier to accomplish that.
Yeah. Okay.
Other things to be done would be at the second stage to create that effect. Again, you would have to gently liposuction around the belly button to create some of that funnel effect because it is a little bit less of fat and subcutaneous tissue natural around the belly button than let's say closer to the pubic hair or slightly higher up to the abdominal wall. That we kind of try to recreate that to some degree.
Hmm. Wow. So much I didn't know about the belly button and the underlying.
Yeah.
So what about going back a little bit to post-surgery? How do you realizing that a lot of surgeons have the same protocol or practice, for what they do, but how do you at Southwest Breast um, dress them afterwards? And what do you tell patients about care? Because there's some patients, and I know they travel to see you too. Uh, and I have had patients, they're not yours, but I've just heard from other patients before. I mean, you probably have this problem. If we don't have
Every-
issues, we're not being
yeah,
truthful with our
yeah,
patients.
yeah.
They'll go home and they'll have like an infection or something if they've traveled, and then it's like, okay, what do I do now?
So it's pretty rare to have an infection, but you can. And most of the time, oral antibiotics at the skin around the belly button helps. A lot of times, that redness around the belly button is called hyperemia, and not necessarily infected. But if I'm concern, I'll start the usual oral antibiotics, and that works. It has not failed me yet if you start early enough. But what we do to dress and secure, so we put sutures on the inside. We don't
Mhm.
usually run the sutures on the outside because those sutures a lot of times give you what's called a railroad track appearance. We
Mm,
have a scar and then suture tracks on each side, and it looks like it's a railroad.
sure.
We put all the sutures on the inside, and also we put the external skin sutures only on the inside of the belly button, not outside on the abdominal skin. It's called a half berries stitch. So we put those sutures in and put all the knots and all the sutures that go through the skin that cause scarring on the inside because nobody can see that.
Hmm.
But the outside, the knots are all buried, and we keep those sutures, and they dissolve on their own about 4 to 6 weeks. They still cause some scarring on the inside, but it's irrelevant because nobody can see that. But it keeps that from separating. And a lot of times when you put so much tension, you shorten the stalk, you're trying to pull this in, and you're relying on some of these skin sutures to help you, and you may not be strong enough, or you're taking them out too early. So we use those sutures and just let them dissolve on their own about 4 to 6 weeks. And the scarring that it's created, it's not visible, not possible to see.
Mm.
But certainly people do have some scar separation, some incision separations, or some edge of the belly button skin necrosis. It does happen.
Hmm.
Most of the time they heal on their own. I can probably count on one hand how many times I had to go back and revise something on the belly button. Most of the things that I do for the belly button would be some steroid injections to soften up the scars and certain genetic type individuals.
Yeah. Yeah. I rarely hear about it, but sometimes I do. Here's another interesting question I got. I only got a couple. Here's the last one. Is there a downside to not reconstructing a belly button beyond aesthetic preferences? In other words, I think what she's asking is, can it create medical issues or make abdominal function weird? That's a
Absolutely
question.
not.
Absolutely
Yeah, no,
not.
absolutely not. You don't need a spiritual aesthetics. And a lot of times, like if belly button's in the way to make the plication or to core strength better, because you can't down where the belly button is, you can't pinch the muscle fascia far enough to create more core strength or bringing the muscles more together. And the
Mhm.
belly button's in the way, and you can't go too tight because then you'll chalk off and kill the belly button. So ideally, that's not the case. You'll lack of blood flow to the area. So and in that area where you need the most plication, you're limited of how much you can do. And there's some plastic surgeons that do cosmetic surgery, cosmetic abdominoplasties. They routinely remove the belly buttons and come back and reconstruct them later or at the same time so they can tighten the waist better for those particular specific reasons. But as far as missing the belly button, there's no functional or medical issues from that. And I realized I didn't answer your question about the dressings. We use the dressing on the belly button called Mepilex. It's an absorbable silicone dressing, impregnated silicone, and it can be reapplied, taken off and reapplied. And we use that for a week, and then we take it off and let it out to air.
Nice. There's a lot to be said about the body's ability to heal and the timing and patience that it takes. You've really hit on some of those key topics today. So I'm going to throw one at you.
Okay,
I know you're
I'm ready.
ready. You're always ready. Um, I like to read and do research and so forth, but are there any new techniques that you've heard about? I read an article. It's a pretty recent article, but to be clear, it was a single center cohort study, so not a large study, but I was really curious about it because I think I've heard this term before. It was called neo umbilicus. Have you heard that?
Yeah, yes.
And I mean,
It,
and again, are there any new techniques? Maybe this is one of them. I don't know. I'll let you share what
so
you know.
neo umbilicus, we can could be a loose term. So neo umbilicus can be used in a DIEP Flap operation or an abdominoplasty, even when you mature the belly button, using the same base of the belly button. They can also be called neo umbilicus, or when you remove the belly button for whatever reason, and in patients with previous operations or mesh or big hernias, the belly button is most likely not going to make it, and we remove them prophylactically. I've done that probably 4 or 5 times, not often.
Mm,
Usually patients with big hernias, or multiple belly button surgeries, for especially for like laparoscopic gallbladder removal or over ovarian surgeries. So and the neo umbilicus is when you have nothing now and it's completely flat and just skin. There's different designs, but the ones that work fairly well is called the four flap design. When you make it's almost like a neck, so you're trying to create skin incisions that have four limbs, and then you take some of the fat from underneath to recreate that funneling, so it's less fat, and you then attach that skin, all those 4 points, they come in like a funnel into the attached to the fascia, and that what creates an opening.
hmm.
And there's at least in my experience, I've had to redo a couple because they do scar a little bit more than you'd want to, and they do kind of blunt and atrophy a little bit more. So that can happen, but that's the technique.
Hmm.
And some patients just do a tattoo. You can also get a tattoo of a belly button of an illusion of an opening. That's all there is to it, and it works very well, just like nipples do, if
Yep.
you find the right people.
I
But
have
that's what
heard.
the neuro umbilicus is.
Yeah, I am so glad you brought up the tattooing of the belly button too, because I wanted to touch on that. And yes, I have heard patients doing that. So, Dr. Matatov, this has been a great conversation, and I've learned so much today. Here's the way I'm thinking of this. I hope patients use this. They're not going to understand or probably comprehend everything. You gave us a tremendous amount of information in a very user-friendly way. Um,
Oh, good.
when I think about going into a consult and all the things you have to talk about, and yet the time frame that we have to talk about it, I hope that this video kind of helps patients understand this process and maybe help shorten the time in the consult because, the hope is they understand it before they come and see you or whoever they choose to go to. So, gosh, I appreciate your time today.
Yeah, no, I think this is great that you're doing this because you're right. The belly button is rarely discussion during the consultation. There's so many other things that we're discussing, and sometimes we'll go over it, sometimes we'll discuss it, sometimes patients will ask. But also sometimes we just don't even talk about it. We're just like, yep, we'll pull this down and we'll recreate your belly button by pulling it through. And that's all that we'll discuss. And for majority of patients, it's fine. But I do think this is very helpful because then, I'm sure when they leave the consultation, all these questions come up and probably don't want to bother people as much or don't call. And so, yeah, this is helpful for them I hope that is helpful.
Oh, I think it will be. It was for me. I learned a lot today. Taking a deeper dive, going under the hood with Dr. Manitoff. Thanks for joining me. Thanks for
Yeah, of
joining me
course.
today. I appreciate your time.
Thanks for having me.
Absolutely.
Same here. Thanks.